So what is the the best investigation or the investigation of choice for pancreatic cancer? Let's see. Maybe some of you can type it on the chat box. How many of you would do a CCT versus AC, MRI, an MRCP, ERCP, PET-CT? Okay. So I see many writing CCT, but there are a few who have written CE, MRI, and MRCP as well. And I don't think there's one right answer, but well, I would say there is one right answer, but MRI is also not wrong, and we'll go through that. So the guidelines state that you have to do a pancreatic protocol, CT or MRI. But if you look at what happens in most places, the surgeons are very comfortable with CT. Plus, CT is I think more reliable or more replicable. With MR abdomen, there are often issues with breathing artifacts. So in that sense, CT is much more replicable, more predictable in getting a good quality scan. So mostly everyone would do a pancreatic protocol CT, but per se MRI is also an equivalent modality if we have good imaging. Ideally, we should do the CT before stenting. So often it's a pancreatic head cancer, they will present with biliary obstruction, obstructive jaundice, and they may be stented as well. So ideally, we should do the scan before the stenting to avoid associated inflammatory changes. Okay. So CT is excellent in catching pancreatic cancer and staging it. Overall, as I said, CT and MRI are both equally good at, assessing the pancreatic mass resectability. But as I said, because of the comfort level we have with CT and um, the confidence of having always sort of mostly being able to acquire a good scan, we would rather do a CT. But if a CT doesn't really solve the issue, if you see, for example, pancreatic ductal cutoff without an obvious mass, or in patients with contrast allergy, we would do an MRI in those situations. And of course, if there are liver lesions, you want to characterize them as benign versus metastatic, then you may consider MRI as well. Okay, PET-CT is another modality, and in India where we do a PET-CECT with a proper pancreatic protocol, it's a fair modality to consider as well. In the West, where we often would do a non-contrast PET-CT, over there you have to do a proper pancreatic protocol CT. I think that would be what you would do. But PET-CT particularly is recommended in patients with a very large primary, very large adenopathy, or markedly high CA19-9 if we don't see any mets on CT, because there is a high chance of them having metastases, which may then be detected on the PET study. All right, we would do a pancreatic protocol CT with the thinnest possible slice thickness, usually is 6 millimeters, no interslice gap. You would give neutral oral contrast, and you would take at least phases, the pancreatic phase, which is 40 to 50 seconds, the portal venous phase at 65 to 70 seconds. And there are articles now which say that, especially if you do not see the mass very well, then a delayed phase helps. Pancreas, just like cholangiocarcinoma, has desmoplastic stroma, which has a lot of extracellular space. So you will see delayed enhancement. The contrast will fill into the extracellular phase on the space in the delayed scans. And hence, you could consider doing a delayed scan if you do not delineate the tumor well on the regular portal venous phase. Okay, and you would reconstruct images in axial, of course, thin axials, and at least on the coronal, if not on both coronal and sagittal. And the reason for that we'll see. The main idea of staging pancreatic cancer is to determine resectability as resectable, borderline resectable, or locally advanced. And for that, the relationship with these two vessels is paramount. And as you can see, actually, the axial to these vessels is not very, it's not the true axial. It's actually the coronal reconstruction, which is sort of a true axial for the celiac artery and the SMA. And because the entire assessment is based on encasement versus abutment of these vessels, you would need the coronal images. Okay, so here's an example of where delayed helps. Here is a patient, and you can see on the venous phase, it's relatively ill-defined, but on the delayed phase, you can clearly see the neoplasm much better. So, if you get the opportunity, do consider taking a delayed scan. Okay, what the surgeon wants to know essentially is resectability. So if it's pancreatic ductal adenocarcinoma and on CT there is metastasis disease, then you can just straight away send the patient for palliative chemotherapy. On the other hand, if you see clear-cut resectable disease, the patient can be operated upfront, or in many cases nowadays, we would still go ahead and give neoadjuvant chemotherapy followed by surgery. And if it's a borderline resectable, locally advanced tumor, then certainly upfront surgery is not performed. We would do chemotherapy. We may even consider doing radiation and then reassess and figure out whether the patient can be operated. Okay, so the management depends on whether we call it resectable, borderline resectable, or LAPC, or metastatic. All right, we have talked about the vascularizations. Most of you know it, so I'll go through it in very brief, and of course, we'll then see the cases and discuss. Okay, so one thing you should always look for is variant anatomy. It is very important in the surgical planning. So, for example, does the patient have an accessory or replaced right hepatic or left hepatic artery? So just to give you, I'm sure most of you are aware of it, but the classic or conventional anatomy, so to speak, is that the celiac trunk gives rise to the right and the left hepatic arteries, right? If in some cases the celiac trunk is giving only rise to the right hepatic artery, the left gastric is giving rise to the left hepatic artery, that is a replaced left hepatic artery. Okay. If the CHA, the common hepatic artery, is giving rise to both the right and the left, and there is still another left hepatic artery arising from the left gastric, that's an accessory left hepatic, right? And the same situation holds true for the right hepatic. If it's arising from the SMA, it would accordingly be an accessory or a replaced right hepatic artery. And there are, of course, other variants as well. Okay, so we have to look at that and also look for stenosis. What happens is during surgery, they often have to clamp the vessels. And if one of the vessels has stenosis, then for example, if the SMA has stenosis and the celiac trunk is clamped, then there may be ischemia, right? Because then there's nothing much supplying the liver. So the liver or the bowel, right? So we have to really talk about the stenosis if it's present. Okay, we all know about abutment versus encasement, but just in brief, any tumor with soft tissue contact less than 180 degrees without deformity is abutment. Okay, so the important thing is should be soft tissue contact. Often you see fat stranding as well, and that is not considered as contact. Okay, it has to be proper enhancing soft tissue, which is abutting the vessel. If the tumor has more than 180 degree contact, then it's encasement. And any amount of contact with deformity is equivalent to encasement. It's a difficult surgery. It's the same thing with veins, abutment without deformity less than 180 degree. Okay, greater than 180 degree abutment greater than 180 contact is encasement. Anything with deformity is again difficult to resect. And this is a deformity again, but it's a specific type of deformity or a specific descriptor is there for it called the teardrop deformity. So both of them are essentially deformities, but these three are more difficult to operate, right, compared to just abutted vessels. All right, on all of this, you can define the resectability, correct? So it's a little confusing. So let's leave the table and let's just go into the very basics. And then, of course, you'll see the cases and hopefully that will clarify things better. But essentially, you have to look, of course, at the primary mass and then look at the vessels, the celiac trunk, the CHA and the SMA, the main portal vein and the SMV. These are the 5 vessels to really focus on. The splenic artery and vein are relatively expendable. Of course, you look at them as well, but they do not determine resectability because you can always do a splenectomy if required. Okay. With a resectable tumor, there should be no contact with the artery. So not even abutment. And for vein, up to abutment without deformity is all right? So if it's abutting the vein without deformity, or of course, if it's not touching the vein at all, that's resectable. Okay. With borderline resectable, for arteries, abutment without deformity is fine. And for veins, encasement or deformity, but as long as it's reconstructible, it is considered borderline resectable. So this is a very important term, reconstructible, because reconstructible is not a radiological defined term. You'll have to ask your surgeon whether he or she feels that this is reconstructible. And often it also depends on whether there's a vascular surgeon available in the institute. So if there's a surgeon who can perform vascular surgery, can put in a graft, then it could be reconstructible. Whereas in another hospital, when such facilities are not available, it may be non-reconstructible. So the definition of reconstructible may vary from institute to institute, which is why often we will not really talk about reconstructible. We just say that there is venous encasement or deformity present or not, right? There are a few more points. One is that, hepatic artery, if it is abutted, right from the origin, from the celiac trunk, up to its bifurcation into the right and the left hepatic trunk vessels, then it is more than borderline resectable. It is locally advanced. Okay, so hepatic arterial abutment is borderline resectable, but if the abutment extends till the bifurcation right from the origin, then it's considered locally advanced. All right. Now, the final thing is locally advanced cancer, of course, and that is if the artery is encased or deformed and if the vein has unreconstructible involvement. Okay, so these are locally advanced tumors, right? Now, just a word of caution that locally advanced need not always mean unresectable. Okay, it just means a more difficult surgery. Okay, so we look at often the sagittal or the coronal images and we look for deformity. So the surgeons can do what is called as a peri-adventitial dissection. They can dissect out the soft tissue up to the adventitia of the vessel because the arteries have very strong adventitia. So it's safe to dissect out over there. Okay, so if the vessel is not deformed, you can, over here, of course, you can see there is narrowing of the vessel, so there is deformity. Okay, so this is something in which they will not do a peri-adventitial dissection. On the other hand, if the vessel is not deformed, then if the caliber is fine, then they could do a peri-adventitial dissection, remove all the tumor around the SMA, and still go ahead and resect. Okay, so just because it's LAPC, locally advanced pancreatic cancer, does not necessarily mean that it is unresectable. And hence, we do not usually write the word unresectable in our reports. We will say borderline resectable or locally advanced pancreatic cancer. Okay, this is called the string sign if there is narrowing because of encasement of the vessel by soft tissue. Halo sign if there is a halo but there is no deformity. Okay. Okay, and then there's one last sort of procedure that they can do, and that is called a modified Appleby or Appleby procedure. Okay, this is distal pancreatectomy and celiac axis trunk resection. So, what happens is for tumors which are very central, involving the pancreatic neck and head, often they will involve the celiac trunk. You can see, for example, there's a tumor, the celiac trunk is involved and the common hepatic arterial origin is also involved. However, you see that the tumor is not extending into the proper hepatic artery, right? And okay, so that is not involved. And it's not reaching the GDA, right? So the GDA, so the common hepatic artery sort of divides into the GDA, the gastroduodenal artery, and then continues further as the proper hepatic artery, which then gives rise to the right and left hepatic branches, right? So if this GDA is patent, often, and in fact, usually, it forms part of the pancreatic or duodenal arcade. So the GDA gives rise to the superior pancreatic or duodenal artery, while the SMA gives rise to the inferior pancreatic or duodenal artery. They both anastomose. And if, for example, there is a cutoff here, often you have blood supply from the inferior pancreatic or duodenal to the superior pancreatic or duodenal, which will reform the proper hepatic artery and supply the liver. So in these situations, you can potentially resect out all of this and still have a patent hepatic arterial circulation, right? So this is called as the modified Appleby procedure, right? It's called modified because Appleby procedure was classically described for gastric cancer causing the same sort of celiac arterial involvement. And when we are doing it as a surgery for pancreatic cancer, it's called modified Appleby procedure. Okay. Okay, so that's sort of what I have explained here. Okay, and then of course, then we use the template to report, which is something I would encourage everyone to use, right? So the template is available on the NCCN guidelines, on SAR, on pretty much all websites. But you talk of the tumor morphology, usually pancreatic cancers are hypoattenuating. If it's a very early subtle tumor, it can be isoattenuating. If it's hyperattenuating, you should think of other tumors like neuroendocrine tumors. It's very uncommon for a pancreatic adenocarcinoma to be hyperattenuating. Okay, you talk of the size, it is often, sometimes of course you can measure the size properly, but there are times when it's very ill-defined and infiltrated and it's difficult to accurately measure. You talk of the location, whether it's head, uncinate, neck, or body tail. I did not mention body tail tumors, but of course for them you will do a distal pancreatic splenectomy. And you talk of biliary and pancreatic ductal radiation. Okay, with respect to arterial evaluation, we sort of discussed all of this, right? We have to talk of soft tissue contact, which is abutment or encasement of the tumor. And you talk of whether there is any vessel irregularity or deformity. Okay, you talk of involvement of the SMA, extension of the first vaginal branch, You would talk of extension of the to the CHA right from the origin to the hepatic arterial bifurcation. These are things we discussed. The first session I did not really discuss in detail, but essentially, a more distal involvement of the SMA indicates a more deep centric involvement, and that is often difficult to operate, but not again inoperable, right? So again, you will leave the decision to the surgeon. All right. And similarly, we'll talk of venous evaluation, right? So again, soft tissue contact, abutment, encasement, narrowing, deformity, extension to the jejunal draining vein. Often you will not see a vessel. There are times the vein is completely occluded, and you may even see collaterals. So you have to talk of that as well. And then you talk, of course, of presence of metastatic disease. In fact, the first thing you would do is look for metastasis. If there are metastases, you really don't have to go into the details of the primary tumor, because it's then just palliative chemotherapy. There's, all of this template is essentially to talk about resectability. But once it's a metastatic tumor, you do not really, you're not going to resect it. Hence, you don't have to go into the details of the vascular involvement. All right. A few last pointers before we really go to the cases. Here's a primary tumor, and you see these lung lesions. Just for you to be aware that, unlike many other tumors where the classic cannonball or round metastasis is what you see, with GI tumors and with pancreatic biliary tumors, often you will see this sort of consolidative nodular opacities, right? And these are also actually metastases. So when you see this, you should confidently call it metastatic disease. How good we are? All these criteria have been developed essentially so that we can identify unresectable disease. What we do not want is for the surgeon to open up the patient and then say that, oops, sorry. What we do not want is the surgeon to refuse surgery to a patient who is potentially operable. Okay, so what we want is a very high positive predictive value for non-resectability, and we are very good at that. We are 90 to 100% accurate. So if we say it is not resectable, that means that it is almost certainly not resectable. Okay, on the other hand, this is always a balance, right? What we do not want is that someone potentially resectable is called unresectable, right? So we want a very high PPV for non-resectability. And of course, that comes at a cost of a low PPV for resectability. So there will be times we'll say, well, this is borderline resectable, this is APC. We will evaluate the patient and decide that, okay, let's go ahead and operate. And it may turn out to be unresectable intra-op. That is fine. The surgeons are okay accepting that. We do not want it the other way around. And the reason for this is, of course, we have kept the threshold low. And the other thing is, pancreatic tumor being a very infiltrated tumor, fat stranding around it, but the fat stranding can also be reactive, right? It's a tumor which incites fibrosis, and it's very difficult to differentiate tumoral spread from reactive fibrosis or post-treatment fibrosis. Often you will give neotherapy, neoadjuvant chemotherapy, and then operate, and again there will be fibrosis, and it's very difficult to differentiate tumor from fibrosis, and hence we will have a low PPV for that. Okay. As I said, the criteria of design is to be more specific for non-resectability than sensitive for non-resectability. And of course, what you remember is that the post-treatment scan, I don't know we'll have the time to discuss that or not, but in the post-treatment setting, as long as there's stable disease, post-treatment meaning the patient gets neoadjuvant therapy and then undergoes another CT scan, as long as the stable disease, if the surgeon feels that this is operable or should deserves at least a trial surgery, then they will go ahead and operate. Okay, so what you want to identify is progression of disease. Increased disease is when they will not operate. Stable disease or improved disease, they will go ahead and operate as long as they feel it's operable. When you do the CT, you would do the CT at least 4 weeks before surgery. So even if there's a, say, 1.5-month-old scan in which the tumor looks resectable, and the patient now comes to your hospital, you would insist on a repeat CT. It has to be at least 4 weeks before the surgery. All right. So it should be a pancreatic CT protocol. It should be at least 4 weeks before surgery. And, what they talk about is this, that the evaluation of the patient should involve a multidisciplinary consultation at a high volume center. What's a high volume center? Institutions performing at least 15 to 20 pancreatic resections annually. And multidisciplinary meaning the surgeon, the radiation oncologist, medical oncologist, radiologist, we all sit together and decide on the resectability of the tumor. Okay. So that's sort of in brief. Of course, it's a very vast topic, but I I thought that the cases are a better way to drive home the point. Okay, so let's go through cases now. So this is a 66-year-old man with mild abdominal pain and discomfort, and we have to decide on the resectability of the tumor. Okay, so let's open case number 1, and let's hope that you guys are able to see the cases. Okay, so please let me know whether you can see the screen, and I'm right now scrolling through case number 1. Can you just put on the chat box whether you can see it or not? Okay, great. You can see it. Phew, great. Okay, so here goes then. All right, so this is the patient, and the patient presents. We have done a pancreatic protocol CT. For all cases, we assume that there are no mets, right? So here we are going through, and right, and then you can start seeing this subtle, soft tissue here, right? I think if I remember correctly, it was well seen on, let's see here. Yeah, so you can see it nicely here, right? This soft tissue, right? So we can see the tumor well. Okay, let's also try this sequence, right? So this is the pancreatic protocol, or rather pancreatic phase, and sometimes you can see it better on the pancreatic phase. I think there's not a huge difference. You can see the tumor here, and you can see it well on the venous phase as well. So I think that's fine. This would have been an interesting one to do a delayed, and probably you would have seen the enhancement nicely on this one, but we don't have a delayed. Okay, so here's the tumor, right? So my question now is for, we can delineate the tumor well. We can sort of give a measurement, and it's something like, something like this, right? Okay. So now my question is there venous abutment or venous involvement? And I will, of course, do a recon. I already said that we need the recons to evaluate everything well. So first, let's look at the veins. Okay, so how many say there is venous encasement versus abutment? So if you say abutment, then just put abutment, and if you think it's encasement, then say encasement. So here is, you can see this is the main portal vein. You can see tumor here. Okay, I hope all of you can see it well. I hope it's projecting well, but this is all tumor along the under surface. With portal vein, again, you have to look very carefully on the coronal, because the under surface is often abutted or encased, right? So without the under surface being evaluated, you may not be able to classify the resectability appropriately. Okay. Right, so most of you have said it's abutment, some of you have said it's encasement. I would say this is abutment, right? I mean, without deformity, right? So we can see here's the SMA, and that is, SMV, and that is abutted. And on the coronal, we also saw that the undersurface of the portal vein was abutted, but nothing was encased, right? If you look over here, this is, an angle of maybe around 120 degrees at max, right? Not more than that. Even if you look here, this is an angle of 120 degrees or something like that, right? So I don't think this is encasement. I would have called this abutment. Okay, and what about the arteries? Do you see the arteries as abutted, encased, or not involved? Okay, so let's put that also for the arteries. And so Vishal is asking, is fat plane maintained between portal vein and tumor? No, the fat plane is lost on the undersurface, as we saw on the coronal, but loss of fat plane is equal to abutment, right? And the tumor is abutting the main portal vein and the SMV, but not encasing it. Right, so the arteries, it was very straightforward. All of you are correct. It is not involving either the SMA or the celiac trunk. So, so this then becomes, what do you think? Resectable, borderline resectable. How many for resectable? So if you think it's resectable, write resectable. If you think it's borderline resectable, write BRPC, borderline resectable pancreatic cancer. Okay, so most of you are right. This is resectable tumor, right? Excellent. So case number 1, perfect. So this is resectable tumor. Okay, so now here is where the MDT is useful. So we discussed this case, and I said this is resectable. Now the question is whether you want to resect upfront, or you want to give neoadjuvant therapy, shrink it further, and then resect. Now, with pancreatic cancer, often it's important, or, there's an importance of getting a R0 resection. R0 resection is when the microscopic margins are also negative. Okay, versus an R1 resection where the microscopic margins are positive. But macroscopically, when they operated, they thought that removed everything. And an R2 resection, of course, was when, even macroscopically, even when they are cutting, they know that they're cutting through the tumor, the margin is positive. Okay, so usually R0 is perfect, R1 is acceptable, R2 is as bad as not operating. All right. So now in this case, when we tell them that, listen, this is the SMV and it's abutting. So if they operate, what will they do? They will scrape the tumor off the SMV, right? Very rarely will they reconstruct, like remove the SMV and reconstruct it, right? Okay, when they scrape the tumor off, what do you think? The margin at this site will be positive or negative microscopically? How many feel it will be positive, right? It will be positive, right? It will be a microscopic positive margin, and they do not want that. So more and more we see nowadays that, because when they scrape it off, this margin will have to come positive, right? Unless they resect the vein itself, if they scrape the tumor off the vein, there will be an R1 margin, a microscopically positive margin. And hence, although it is a resectable tumor, it is almost certainly going to be an R1 resection, an R0 resection. Hence, they will, now in this case, they decided to give neoadjuvant chemotherapy, hopefully shrink the tumor. Often, as I said, the tumor will not shrink, it will just become fibrotic. But when they resect the tumor, then hopefully the margin will be fibrosis and not viable tumor. And that will be an R0 resection. Okay, so that's what the decision was. The patient is on chemotherapy right now, and hopefully that was the right decision for the patient. Okay, so that's the first case. Yeah. Now, case is 64-year-old man with jaundice. Okay, so again, we do a CCT. Of course, there's an ultrasound which talks of, suspicious pancreatic mass. Okay, so you see this now. All right. So let's again, I think the tumor is easily identifiable. This is all tumor, right? You can see it. Right. So all of this is hypoenhancing. That's tumor. Okay, it is causing the ductal cutoff here, right? So the duct is fine till here, and then here is the ductal cutoff, and all of this is tumor. So it's an hide and unmet process tumor. Now the question is again vessels, right? So there is no metastatic disease. So let's look at the vessels. Now here's the main portal vein. I'm scrolling down, scrolling down. Here's the this is the portosplenic confluence. Now here's the SMV. I'm scrolling down and scrolling down. So what do you think? What is happening to the SMV? Is it abutted or encased? You can type what you think. Is the SMV abutted or encased? Okay. Yeah. So pretty much all of you are saying it's encased. Now there's one more thing. Okay, people are saying abutted, but most of you are correct. You're saying it's encased. Now you can see that this is more than 180 degrees, I would say. And what is happening? Is there deformity? Okay, so okay, so some people are saying no, some people are saying yes. So there is deformity. If you look at the caliber of this vessel, it's big, and when you go down, it's pretty narrow, right? It's pretty narrow. It's very, very severely narrowed here. And then you go down further. This is the normal caliber of the SMV, right? This is how it should look. But as we can see, it is engaged to a level that there is significant narrowing, which of course means there's deformity. So this is SMV, encasement, and deformity. I mean, encasement becomes moot. Once you see deformity, you just say there is SMV narrowing or SMV deformity. Without complete, of course, you still do see the SMV. Now we come to the arteries, and maybe, yeah, we can use the sequence, the pancreatic phase sequence to look at the arteries a little better. Okay, so now what do you think is happening to the arteries? Okay, so A, notice that this is unusual, right? Let me just go from the top and see. Here we're going down, 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 down. Okay, there is a vessel coming up here. And what is this vessel? What is this vessel? I'm tracing it, I'm tracing it. and that's the gastric, right? It's the left gastric artery, but it's arising directly from the aorta, right? Now I go further down, what do I see? I see this vessel, and what do I see? I see the SMA arising from this, so this is probably the SMA. But I go up and what do I see? I see that even the hepatic and the splenic are arising from this vessel, right? So it's a common trunk, right? It's a common sort of SMA and celiac trunk. Okay, so this is it's an aberrant anatomy or a variant anatomy rather. Okay, but let's now look at the variant anatomy and say what do you think? Okay, so the first thing we'll mention, right? The first thing we have to look at is anatomy, and here we will mention that listen, this is variant anatomy. Okay, with a celiomesenteric trunk, right, which is giving rise to both the SMA, the splenic, and the common hepatic arteries. Now, what do you think is happening? Is this abutment versus encasement? Okay, so the surgeon might say, okay, fine, this is reconstructible involvement, it's fine. So the next question they'll ask is, but what about the artery? Is this abutted or encased? So what do you think? Okay, let me ask. Okay, so who's saying abutment? I'm saying encasement. All right, so I see abutted. So pretty much all of you have said abutted. All right, perfect. So this is exactly what I wanted to highlight, that it's very difficult to talk of abutment versus encasement without a coronal, because as I said, the true axial for the artery is the coronal, right? So now, if you look, what is happening? What is all this, right? Can you see? The tumor is going not only, yeah, so you can see all of this is tumor here, and it's also involving the origin of the common hepatic. So all of this is tumor, and obviously in the axial it was difficult to evaluate this, but on the coronal you can see there is a good amount of tumor around the coelomesenteric trunk, right? You can see it here, 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 right? So on the coronal, what do you think now? After seeing the coronal, how many feel it's abutment? How many feel it's encasement? Okay, so many of you have now changed track, right? So many of you now feel it's encased, which is great. This is the point I wanted to drive home, that you have to look at the coronal before deciding on abutment versus encasement. Because there are times then this will happen. You will look at the coronal and you'll say, oops, this is encasement. So I'm glad that you have all looked at this and decided on the right thing. So this is encasement, which of course means this is locally advanced pancreatic cancer, right? So this is locally advanced pancreatic cancer and needs neoadjuvant chemotherapy, and we'll reassess after that and then decide on whether this can be operated or not. Remember, just because it's encased doesn't mean that it is inoperable. They can probably still go ahead and do a periadventitial dissection. I think I'll also show you the sagittal, because it's a pretty cool picture, right? To see that coelomesenteric trunk. Right, you can see that here. A common trunk, and that is why it's such a big, bulky artery, right? Which is giving rise to both the SMA and the celiac and the CH. So that's the coelomesenteric trunk. Okay, so it's not narrowing the artery, thankfully, right? So hopefully after chemotherapy, there is a chance that it shrinks or at least remains stable, and they could consider periadventitial dissection. But that's for, of course, the surgeon and the multidisciplinary tumor board to decide. Most importantly, you have told them that this is right now LAPC. Okay, so that was the teaching point of this case. Okay, and that was, of course, the decision. Urgent chemotherapy and reassess. Unfortunately, the patient progressed on chemotherapy with liver metastasis, and hence the patient was not operated. Okay, and that is, one of the other things about chemotherapy. We feel that, oops, if we tried operating this patient upfront, perhaps the patient's tumor would have come out and he would not have progressed, right? But this is, pancreatic cancer is assumed to be a systemic disease, meaning whenever you detect it, the assumption is that there is micrometastasis everywhere, especially for the larger tumors. And hence, it's always a good idea to give neoadjuvant chemotherapy, because it sort of differentiates the patients who respond or remain stable, and those are the patients who will probably do well on surgery, versus the two patients who anyway progress on chemotherapy, and these patients would have never benefited from the surgery at all. You would have operated, it takes a month or 6 weeks at least for the post-op recovery. And by then the patient have anyway progressed, right? I mean, the patient progress even with chemotherapy. If you just operated, the patient would definitely progress with liver metastasis much before that, right? So in that sense, it's a good to give neoadjuvant chemotherapy. Okay, we're going to leave case 3, but go to case 4. Case 3 was similar again. It just was talking about the same point of using the coronals. Okay, now here's a lady with jaundice, case 4. And this one, if I remember correctly, is a relatively straightforward case. Let's see. Yeah. Right. So this is what we often see, right? I mean, so here's a tumor. You can see the pancreatic duct. Here's the cutoff. You can see a relatively well delineated tumor, right? It's hypoenhancing. And what do you think? What is happening? So let's look at the vein first. Okay. Here's the vein. So the vein is patent, right? I mean, the SMV is not involved clearly. And as we go up, we can see that the portal vein is at least abutted, if not encased, right? Okay, but you wouldn't break your head over that because you are obviously seeing something much more important, and that is that the celiac trunk is clearly encased, right? So here's the celiac trifurcation. You can see soft tissue right over there, involving the trifurcation, involving the CHA, right? And this pretty much goes for a pretty much long segment, right? So this is locally advanced pancreatic cancer, and this is an extensive disease which is highly unlikely to come for surgery. Okay, so I had also mentioned about sometimes when you can operate such patients, but you can see here that the GDA origin is also clearly involved. The gastroduodenal arteries is involved. You really don't see it very well, right? So all of this is tumor, so it's a pretty extensive amount of involvement of the common hepatic artery, and it's reaching the bifurcation, right? So this is the left and the right hepatic arteries. So the common hepatic bifurcation is here, and you can see soft tissue reaching the bifurcation. So right from the origin of the proper common hepatic artery till the bifurcation of the proper hepatic artery. So clearly this is a locally advanced pancreatic cancer. This is one of those which is unlikely to ever turn up for surgery. Okay. Let's see. So that was case number 4, and this was, we discussed it and we all agreed that this is likely to come for therapy, and so this is palliative chemotherapy. So here we will say that, with a locally advanced pancreatic cancer, as I said, some of them are operable, but majority are not operable, or many of them are not operable, and we can make out on the baseline scan itself. So we call these the never tumors, or the ones which will never be operable, and those we will straight away identify for palliative chemotherapy. And the ones in which it is potentially still operable, be it a heroic surgery, be it with vascular resection, etc., we will call it neoadjuvant chemotherapy instead of palliative chemotherapy, right? Curative intent therapy. Okay, now this is a lady with abdominal pain. So this is case number 5. Yeah. Yeah, so now, a couple of interesting cases. So I'm going to show you 5 and 6 together, because this is interesting. So now these are more inferior tumors. So these are more uncinate tumors. You can see that they're not presenting with pancreatic ductal dilation at all. They are uncinate tumors predominantly, and it's a relatively well-defined tumor. You can delineate the tumor very well. Okay, now let's see what's happening. Okay, now is the SMA. So let's leave the celiac, right? The celiac is fine. As I said, it's a lower tumor. The celiac is fine. Common hepatic is fine. Main portal vein is fine. We go down to most the SMV and SMA. All right. So what are we seeing now? So with the SMA, as I go down, you can see that now there is narrowing of the SMV, and I'm going down further. It's almost completely occluded, right? Narrow speck left. I think over here it's completely occluded. But then you sort of see reformation. So I would say it's near completely or completely occluded. Definitely there's a deformity, right? But that's what we see. And then here is the SMA. Okay, and here the SMA again, what do you see? You see encasement, right? I mean, here I don't even need to look at the coordinates. I can say that this is clearly encased. It's more than 180 degrees, right? So there's encasement without deformity of the SMA and encasement with deformity of the SMV. Let's see if I can show it on the arterial phase images. Um, hmm. Yeah, so that's the okay. So here's the SMA, SMA. You can see the tumor. All right, we're going further down. So what I want to sort of okay. So here's the first jejunal. You can see this branch here. That's the first jejunal. Yeah, that's one thing I wanted to show you. So with the SMA usually the proximal branches are the pancreatic duodenal and the colic arteries, right? So, for example, here what you see is the right colic artery coming up. Uh, Sometimes you can see the middle colic coming up, and the one which is going towards the left, this is the jejunal branch. Okay, so you can see that the tumor is pretty much encasing the SMA even up to the jejunal branch, right? So first jejunal branch is encased. Okay, so this is a pretty deep tumor with pretty deep mesenteric infiltration, and that's unfortunately the case with uncinate tumors. They present a little later because there's no J, and they will often have involvement of the SMA and SMV deep into the mesentery. Okay, so this is one case, and here's another case. Right, so now over here, what we see is another tumor which is not causing a lot of pancreatic ductal dilation. It is again an uncinate tumor. Um, you can see that the SMA is encased, but pretty early on, right? The SMA is encased pretty early on, right? But the encasement stops a little proximal, right? It's not as deep as the previous case that we saw. Of course, it is a long segment involvement, okay, but slightly less deep into the mesentery. The deeper into the mesentery, the more difficult or impossible it is for them to resect. Because once the jejunal branch is involved, if you're resecting, you have to resect that part of the jejunum as well, right? And if it's involving much of the root of mesentery, then there's no way you can operate because you cannot resect the entire small bowel, right? So then that tumor, right? Okay, so both of these cases we evaluated in the MDT, right? And here as well, without the MDT, it becomes very difficult to really talk. So both are LAPCs, both are locally advanced pancreatic cancer. But with this first lady, the plan was palliative chemotherapy, and that's because of the deep encasement. The surgeon felt there is no way that they will be able to operate it. Now let's look at the sagittal of the coronal of this case. Yeah. So here again, you see a pretty long segment involvement of the SMA. But you can also see that there is no deformity, right? The SMA remains patent, right? Patent and not narrowed, right? So there is no deformity of the SMA. Okay, so with this second case, they felt that it's possible to operate because it's not as deep as the first case. So we gave emergent chemotherapy, reassessed, and after reassessment, the tumor was relatively stable, maybe marginally improved. The plan was then to give a trial resection with SMA divestment, and that was done in July 25, and the patient is cancer free up to the last follow up in January 26. So as I said, locally advanced pancreatic cancers can also be operated, but you need a very robust decision making process. Those who deserve a trial resection are selected for it, while those who will not benefit are not selected. Okay, so this is something that we cannot put on the report. You have to be there in the MDT and discuss. Okay, now here's case 7. We are closing to the end of the cases. So here's case 7. All right. Yeah, so here's the tumor. Now here in this case, so the previous tumor I showed you was uncinate, right? So the earlier tumors were tumors with OJ. The previous two tumors were uncinate, which was causing a lot of SMV involvement. Now this one, on the other hand, is higher up, right? It's more distal pancreatic tumor. So you can see that the pancreatic body involved, sort of reaching the neck and the tail, right? And you can see that the tumor is infiltrating and encasing the celiac trunk pretty massively, right? And the SMA is abutted here, right? So the SMA is abutted. And of course, you would say, well, we have to look at the coronal before we decide on abutment versus encasement, but we'll do that. So here's the tumor. You can see that not only is the celiac encased, it's also narrowed. The celiac is narrowed, the origin of the hepatic artery is narrowed. You can clearly see this narrowing. Okay, so the celiac trifurcation, encasement, and narrowing. The origin is probably still free, right? And tumor here. So the origin is free, but most of the celiac trunk is encased and the proximal common hepatic artery is encased. All right. Yeah, and again, we see this here, right? So the celiac trunk is encased and narrowed, but with regards to the SMA, it's still, I think, less than 180 degrees. So there's abutment of the SMA. Okay. So that's what we said, right? So now this becomes locally advanced pancreatic cancer. But remember, I told you of a specific uncommon surgery you can do in patients with a central tumor, right? With celiac arterial basement. You can, okay, so just to show you the veins are all fine, right? We can see fat around them, so veins are not involved, right? So this is the classic case for a modified Appleby procedure, which is what was done in this case. So we gave neoadjuvant chemotherapy, reassessed for surgery, underwent modified Appleby surgery successfully. Unfortunately, the patient developed metastasis after surgery and expired 14 months post-surgery. Okay, so technically we were able to resect it, but pancreas is, even resectable pancreatic cancer will usually recur. It's a very poor prognosis tumor. So, we have to give it our best shot. Okay, I have a couple of more cases. I think the first one I want to show is this. And here, I think this is just to again highlight the importance of looking at the anatomy. Okay, so here's a tumor where you can see it's a pretty big mass, and you can see that, yeah, so here's the celiac trunk, and it's involving the celiac trunk as its bifurcation. I would say, the LGA is coming higher up. LGA, the left gastric is rising here. I go down, and I see the splenic and the celiac and the common hepatic, and there is soft tissue encasement at that level where the celiac trunk is dividing into the splenic and the common hepatic, and the common hepatic is clearly encased, right? So per se, this is a very difficult one to operate. Okay, it's a pretty large mass, and we still have the patient is right now on chemotherapy, neoadjuvant chemotherapy. So I can't tell you what happened eventually, but when we the first thing, as I said, is look at variant anatomy, and what do you see? You see that there is the left gastric artery arising pretty much proximally from the celiac trunk, so not involved by the tumor. And then here's the left gastric artery, and then you see, so this for ligamentum venosum. If you see a vessel coming here, that's an accessory or a replaced left gastric artery. Sorry, left hepatic artery arising from the left gastric artery. So here you can see this vessel, and when you see this, you know that there is another, at least there is one left hepatic artery over here. You go down and you check what is happening with the main hepatic artery, and you can see that it is giving branch to the left as well. So what we see up here is a accessory left hepatic artery. Okay, so there's an accessory left hepatic artery, which means that, well, maybe at least the left liver lobe will get some supply even if we try and operate. And then we go further on. What do we see? We see another vessel arising from the SMA. So the replaced or accessory right hepatic artery will always go behind the portal vein. Remember that if you see a vessel behind the portal vein, then that is a replaced or accessory right hepatic artery arising from the SMA. Okay, so this is the hepatic artery. Again, if we trace the proper hepatic artery, I do not see any branch to go into the right. So this is a replaced right hepatic artery. This patient has a replaced right and an accessory left hepatic artery. And of course, with that, everything changes, right? Now we are much more comfortable. We can consider resecting all of this, knowing that the right hepatic artery is arising from SMA and the right hepatic lobe will be supplied by, and there is an accessory left hepatic artery arising from the left gastric and the left liver. So now we are much more comfortable considering surgery in this patient than otherwise. It was very difficult to operate. Okay, so this is the importance of looking at the anatomy. All right, I have one more case to show. Okay, this is a patient who came with, I think, no, nothing over here. Maybe I am confusing the cases. Let's see. Oh yeah, so this is a patient which came with. So yeah, so this patient came with multiple liver mets, and we are wondering what's happening. You can see some splenic infarct over here, right? And everyone was wondering that, well, is this metastatic tumor? Is this a primary intrahepatic cholangiocarcinoma? What is the pathology? Okay, so whenever that happens, always look carefully at the pancreas. CA99 was high, so we thought it was either pancreas or biliary, right? It's and both. Cholangio also made sense, but if you look carefully now, why is there splenic infarct? Usually with a pancreatic mass, you will see the splenic vein occluded, right? So here you don't see the splenic vein at all, right? It's occluded, Well, it's going a little faster, but yeah, let's trace the maple vein that's over here. And here is the splenic vein. And after that, it just stops, right? It's occluded. And then you will start realizing that what we see over here is not pancreatic parenchyma. This is lobulated pancreatic parenchyma. This is infiltrated soft tissue, and that's tumor. So this was a pancreatic tail tumor involving the splenic vessels, causing infarct and with diffuse liver metastasis. So always look very carefully at the pancreas because it can hide very subtle tumor, and particularly when it's a tail tumor, it may be very small. There is no ductal dilation to give you a hint, no ductal cutoff. So look very carefully at that time. Okay, let me show you this last case before we wind up. So now here is a tumor. And you can see that, it's a pretty big mass. What is happening to the pancreas? The uncinate is fine. The head, the neck is involved. And well, what is happening to the pancreatic tail? I mean, you can barely see it, right? It's just all atrophied, right? All you see is this big mass. Okay, so this looks like a pancreatic mass, right? But there are some issues. You can see it's pretty big, right? It's a pretty big mass. It is encasing a lot of vessels, it's causing all the vascular involvement that you would expect. But this is a very big and well-defined mass, isn't it? And you would generally not see such a huge pancreatic mass without the patient already dead, frankly, or with widespread metastatic disease. And you would generally see a lot of fat stranding and infiltration. It won't be so well-defined, right? So when you see such a big mass, and as I said, I wouldn't say this is a hypervascular, but it is not very hypoattenuating either, right? So when you see such a mass, which is well-defined, which is big, then you have to raise your suspicion that it's not pancreatic ductal adenocarcinoma. It could be a second most common tumor, PNET, pancreatic neuroendocrine tumor. Okay, so classically they're supposed to be hyperenhancing, but not always the case, especially the large tumors are not like that. Classically they will not show ductal dilation, etc. But very often we do see ductal dilation, we see vascular encasement, we even see tumor thrombus, in fact. Okay, but when you see a large mass like this, relatively well defined, no infiltration, the fat around it is fine, then you should think of a PNET. Okay, so this turned out to be a pancreatic neuroendocrine tumor. All right, so those are the cases I wanted to show you. All right, so the take-home points are one, the most important thing is to have a very good pancreatic CT protocol and have those coronal reconstructions that we talked about. First thing is to rule out mets. Okay, if there are mets, you just stop there and then you don't have to go into the details of resectability. If then you focus on the resectability. Use the template, cover all the points in the template. For example, variant anatomy present or absent is a very important point to report. Celiac artery stenosis present or absent, very important point to report. And unless you use the template, you may miss such points. Okay, coronal reconstructions are very useful, and MDT is the key to optimal management. Many times, a BRPC versus APC, operation versus not operating, it all depends on the discussion as a team. You would identify the tumor, deal in the tumor for them, and they will say whether they are confident operating it or not. Okay, also remember surgical capabilities may vary from institute to institute, and hence it is that you don't label anything as unresectable. You say borderline resectable or locally advanced pancreatic cancer, but avoid using the term unresectable. Okay, so I wanted to end with this slide because today is the foundation day of my hospital. We celebrate 5 years of the 85th birthday. So I thought I'll end with this slide. Um, so we have finished well in time.